Yes. So, I mean, obviously, there are many reasons behind that. I want to point out four major reasons for that. First, alcohol use disorder is a chronic relapsing disorder. So, regardless of a liver transplant, they will have have a chance in their lifetime, anytime, that they could have a relapse. Well, second, for liver transplant evaluation, those patients, when they are evaluated for liver transplant, there are a couple of transplant criteria, like selection criteria that were developed. But then, those are mostly retrospective data analysis. They have limited accuracy. Um, and in addition to that, post liver transplant, there are also some risk factors that they couldn't catch. And then, when those patients relapse, there are a lot of barriers that they don't want to engage in being treated. One of them is called a stigma, because they don't want people to know that they have had a relapse. And lastly, when we talk about alcohol use disorder, when they have post liver transplant relapse, especially if they have severe relapse, um, if they don't get treated, the outcome is really bad. A lot of them develop recurrent alcohol-related liver disease that will make them ineligible for liver transplant. So, well, again, as I said, alcohol use disorder itself is a very complicated process. On top of that, those patients have liver disease, So, and those patients also may have a lot of mental disorders like psychiatric comorbidities, depression, anxiety, and because of the alcohol drinking, they also have issues with social support. So it's a very complicated problem, and only hepatology itself is not going to be able to fix the problem. That's why we need a multidisciplinary care model that we could integrate hepatology, addiction specialist, like for example, addiction psychiatrists or addiction medicine doctors, and probably social workers to get involved in this complicated population to optimize their care. So at MTH, we established one of the first of its kind of co-located um, multidisciplinary alcohol use disorder clinic after liver transplant. So LIFT means long-term individualized care after liver transplant. So basically what it means, we provide long-term care because those patients needs long-term follow-up because of any time, they have any chance they could relapse. And individualized, meaning everybody has their own comorbidities, own issues that we want to follow them. And lastly, we want to take this very supportive approach, non-stigmatized approach. We want to support them, not just survive, but also thrive after liver transplant. Have a very good quality of life. That is the goal of doing liver transplant for those patients. Regarding our outcome, we have two groups of patients. One group is a prevention group, which means, we start to see them within 3 months of their liver transplant so that we can track them and prevent them from relapsing. We get them engaged in care. We offer them, we help them with behavioral therapy. We prescribe pharmacotherapy for those patients. In that population, we have seen over 20 patients so far, but we have not had a single sustained relapse. There's only one patient who had one-time slip that he reported us, but his path was actually negative, which proves that he trusts us a lot. You know, the other group, which is those patients who have relapsed, those patients' population is a little bit tougher to take care of because of long, already heavy relapse. Um, what we did again, we offer our support for them. We earn their trust, and eventually we were able to get over 70% of those patients to be engaged in some sort of care. Um, and the outcome is also good, which is over 60% of those patients achieved either reduced alcohol drinking or be able to achieve sobriety. Um, well, I mean, is this the best outcome? It is not. That's why we want to, uh, make this preventative care as the most effective care. I think this is really something that I think we should push for. Yeah. So again, the implication is that I think I've touched a little bit. So those patients, we try to prevent them from relapsing, because once they relapse, they lose some of the incentives after transplant because they already got a transplant, right? Um, and then even if they have relapse, if we're able to earn their trust, they will be able to get engaged in the care, and we should aim at harm reduction. And obviously, we want them to stay sober, but sometimes they struggle with this. So we aim at how can they reduce their drinking instead of completely stopping. I think that's something that I think in those heavily relapsed patients, that will be the goal. And then for the future, so what we have realized is that for those, yes, we all know that we can we can predict some of the high risk patients, right? But we have noticed that some of those that we consider as low risk relapse. For example, I've seen a patient with 5 years of sobriety that she has relapsed, very severe relapse. So that's why eventually we decided from this year that we wanted to expand to the patient population to everybody who has alcohol as a contributing factor to their liver disease. We see them in our clinic at least once to assess their post-liver transplant risk factors and give a comprehensive assessment. And then, if they have very low risk, we could see them in a longer interval. But if we find any high risk factors in those patients, we start to follow them very closely. I think by this approach, will provide an even better care for those patients, uh, regardless of their risk of relapse.